Hi. We are into the 87th webinar, and today we will be talking about the stepwise approach to cyanotic congenital heart disease, the second part. In the first part, Dr. Ramakrishnan had very beautifully explained how to approach, how to diagnose, how to have various differentials, and how to differentiate between common cyanotic congenital heart disease. And he had given very important and relevant tips and tricks to us. So we'll be continuing our discussion in this part too, which will again be further, explanations of the previous discussion. So we wholeheartedly welcome our very dear, our very own Dr. Ramakrishnan, one of the best speakers we have in our this platform. Over to you, sir, and welcome once again to Delhi CSI, this wonderful platform. Please, you can share your slides.
Yeah, thank you, Dr. Mohit, for the opportunity. So I think,
please, yeah.
So I'm just sharing my screen. So is my screen visible?
Yes, sir.
Yeah. So, dear friends, I think we are now going to talk about the extension of my last lecture, which is going to be approach on cyanotic congenital heart disease in adults. So I thought of oversimplifying it, and that's why I said that if you find an adult with cyanosis, it's going to be either TOF or Eisenmenger, or very rarely it can be Epstein's anomaly. And rest of them are very, very uncommon. Like sometimes you can get a PS with ASD in your exams, or very, very rarely you can have some total anomalous pulmonary venous connection and a DVRV VSD PS, which is not a basically something like tetralogy only you will get. Very rarely you will find some DVRV with PH and all those things that will look like an Eisenmenger syndrome. So by and large, you can fix yourself with TOF and Eisenmenger and Epstein's for all practical purposes. 90 to 95% of all your patients that are kept in your exams will fall into either TOF or TOF physiology, some anatomy of TOF physiology, or various forms of Eisenmenger's and Epstein's anomaly. So how do you approach a CCHD? Very simple. Most commonly, the question that comes up to your mind is always going to be TOF or Eisenmenger syndrome. So you decide about the progression of the disease, the cyanosis, how it is progressing, how much cyanosis is there, history of spells and squatting, they all favor tetralogy. So rarely Epstein can happen in various forms, and you should always be wary of Epstein whenever you find a adult with cyanotic congenital heart disease. They can present to you with cyanosis, they can present to you with limitations of effort, they can present to you with palpitation. So various presentations are there. They can present in neonatal age group, they can present in later in life also. So this much we have discussed. So we have discussed in depth about tetralogy and various physiologies, how do you clinically distinguish them? And we have discussed about some of the variant forms of tetralogy that may be kept in your exams at times. So that will make your life very easy. Now in today's discussion, we will be discussing about how do you differentiate between various forms of Eisenmenger syndrome and what are the common features of Eisenmenger syndrome, and some discussion about the various other uncommon conditions that you may encounter in your exams. So oftentimes, many of my co-examiners are very fond of asking this question, that is, what happened, how many patients of this was there, that was there in Paul Wood series. But for me, I think that this is history. I think we have moved on, and Eisenmenger syndrome has also moved on from the days of Paul Wood series. But still, I think it gives you some fundamental understanding about how big a defect has to be to produce Eisenmenger syndrome, and all those things are very nicely seen. And depending on how much cyanosis you get and at what age of life you get cyanosis, all those data are well given, and those are all mostly textbook data. But it is better to know the Paul Wood series, and some examiners are fond of asking these things. So these are some of the unfortunate stories that we get in India. So this was a VSD, which was seen and advised cardiac surgery, say at the age of around a year or so, 1.5 year old child with a VSD. You can clearly see the large heart. You can see the pulmonary plethora with evidence of pulmonary hypertension. The patient was cleared for surgery and sent for surgery, but now the patient did not undergo surgery. The same patient comes back maybe 10 years down the line with this X-ray. I think Anybody who works in a government sector, anybody who works in a high volume center would have seen patients like this. And it is not often the first time that Eisenmenger syndrome patients are diagnosed with having a hole in the heart. Most often than not, they would be diagnosed earlier. And oftentimes they are either advised surgery, they didn't undergo surgery for various reasons, or they are not advised surgery. They said that many people used to say that we have been told that the child has a hole in the heart, which will settle on its own over time. If it doesn't happen, then you can follow it up. Either they have visited again and they thought it's going to settle, but it settles in this fashion. So what are the major conditions in which group Eisenmenger syndrome falls into? So commonly, there is a confusion, like the pressures are very high. What happens to the pulmonary blood flow? If somebody is very blue, the pulmonary blood flow is generally reduced in both tetralogy as well as Eisenmenger syndrome. There are some situations where pulmonary blood flow is increased. At the same time, patient can be cyanosed. So Eisenmenger physiology is generally due to large ventricular septal defect, large patent rectus arteriosus, aortopulmonary window, atrioseptal defects, and a large chunk of group of conditions called a cyanotic congenital heart disease with increased pulmonary blood flow that will encompass your truncus arteriosus, single ventricle with PAH, various other situations where there is increased flow and then along with the PAH. Oftentimes, VSD with PAH, patient in an infancy, like for example, if you find a small child, you never label the diagnosis of Eisenmenger syndrome. Eisenmenger syndrome is irrecoverable increase in PVRI with a right to left shunt. Once you get a right to left shunt happening in a left to right shunting lesion, that means most often than not, it is irreversible with a few exceptions. So never label a patient with Eisenmenger in infancy. So one of the reasons why this happens, like wrong labeling of Eisenmenger syndrome in infancy or early childhood, are saying that VSD you can wait and watch for, even a large VSD you can wait and watch, is because of lack of concepts. One of the important concepts that you understand is at what age a large VSD will Eisenmengerize. So invariably, I ask this question in exams. Most of the people who are not exposed to pediatric cardiology will give me a wrong answer. So what will be the answer here? Less than 6 months? Is it 2 years? Is it 10 years? Is it 20 years? Oftentimes, I get an answer saying that, okay, a large VSD, generally Eisenmengerization happens because most of the time patient becomes symptomatic because of Eisenmenger syndrome in second decade. So many will say that this is second decade where the large VSD will Eisenmengerize. One important concept that you understand, Eisenmengerization is not one door where a patient passes across this door means he is Eisenmengerized. If the patient is across the other side of the door, he is operable. It is not. It is a kind of a process. It happens over time. The increase in PVOD, the pulmonary vascular disease, obstructive pulmonary vascular changes, keep on happening. And they start very early. And most of the patients who become Eisenmenger syndrome then generally become inoperable. The proportion, significant proportion of them will become inoperable by 2 years of age. This is a very, very important concept for all adult cardiologists to understand. You find a child with, say, 6 months large VSD, there is no point in waiting today. The patient should be immediately operated, even if the patient is asymptomatic. And unfortunately, most of the patients are generally asymptomatic. Why? For symptoms to develop, you need large flow. Large flow produces more heart failure, more failure to thrive. Whereas when they become Eisenmenger syndrome, the flow reduces. So there is no heart failure. The child actually goes through a phase of suck, rest, suck cycle. Everything is there. By around 1 year, 2 years, the child settles down. Everything looks all right. The patient thinks that the child is doing well. There is no problem. So most important thing to understand is a large VSD Eisenmengerizes by around 2 years. When do you find a VSD or a large PDA Eisenmengerize early? That is less than 2 years, maybe around 6 months. When do they Eisenmengerize? Whenever you find a VSD associated with another reason for cyanosis, that means another reason for mixing or transposition, like for example, a TGA VSD, Eisenmengerizes even by 6 months also. So CCHD increased QP with VSDs, generally Eisenmengerize early. Point number 1. Point number 2, some of the genetic syndromes, patients may Eisenmengerize early. A classic example being Down syndrome. So why do Down syndrome children Eisenmengerize early? we really don't know the answer, but some of the explanations have been presence of URIs, recurrent URIs, presence of adenoids, and that also contributing to pH. And there could be some unknown or known genetic variation that happen that also predisposes them to pH. So by and large, all large VSDs may Eisenmengerize by around 2 years. The proportion that remains operable goes down steeply after 2 years. And sometimes large VSD may Eisenmengerize very early. Now coming to the another important question, when a ASD will Eisenmengerize? When a pre-tricuspid shunt will Eisenmengerize? Is it 10 years, 20 years, 40 years? So generally ASD Eisenmengerization, pre-tricuspid shunt Eisenmengerization happens later in life. And there is a subgroup of patients. For example, we would have seen maybe around in my life, I would have seen around 20 patients, infants with ASD who are having severe pH. There now the current thinking is that most of the early Eisenmengerization with ASD that happens rarely, is because of a superimposition of a primary pH kind of a situation on ASD. That is the kind of a thinking that goes on. Because their prognosis is very bad, they are generally very progressive. And this is what we all think like. Most likely it's a combination of primary pH with an ASD. Generally ASD Eisenmengerizes by around 3rd and 4th decade of life. One more important concept in pre-tricuspid shunt as compared to post-tricuspid shunt is at what pulmonary arterial pressure ASD will Eisenmengerize. Commonly, we all think that Eisenmenger syndrome means systemic pulmonary arterial hypertension. So in my life, I have seen patients beginning Eisenmengerization or inoperability happening at around, say, 2/3 of systemic pressures in ASD. So another important concept that you have to remember is pre-tricuspid shunts, Eisenmengerization can happen much before they reach the systemic PA pressures become systemic. So I've tried to introduce some important key concepts. I will reiterate again. VSD, large VSD Eisenmengerizes starting by around 2 years of life. In few situations, it can happen very early also. And ASD generally Eisenmengerizes by around 3rd and 4th decade of life. In some rare situations, it can Eisenmengerize early, whatever PA pressure becomes suprasystemic in ASD. That is, we all think that mostly it is a superimposition of IPH on top of ASD. So two key concepts that you have to understand in an ASD compared to VSD pH, that means pre-tricuspid shunt compared to post-tricuspid shunt, is the PA pressures are usually systemic because you have a large VSD. The systemic pressures will be there in a VSD or a PDR and AP window. The PA pressure has to be systemic. Whereas in an ASD, it can be subsystemic and it can be rarely suprasystemic also. So these are the important concepts hemodynamically you have to understand. So these things I've seen. One more important thing that we have to understand is the closure of the defect is only detrimental when the obstructive pH has developed. So many a times, often I find people who are not in the field, who are not taking the decision of operability decision day in and day out, often tend to give a chance. They are a patient borderline, we give it a chance. No, it should be the other way around. Why? I will tell you. The median survival in Eisenmenger syndrome is slightly improving over time. I think it is around 30 to 40 years of age in uncomplicated lesions. So one important thing in diagnosing and managing hypertension Eisenmenger syndrome patient is the most important death that happen, 20% of the death that happen is because of a medical procedure and an ill-advised activity. So that's a very important thing that you have to understand. Survival is clearly better than in patients with IPH, and unwarranted surgical closure hastens death. A patient is generally, if you find a patient who is 18-year-old, who is mildly blue, but you do some way calculation, PVRA comes to around 10, 12, and then you give oxygen, the PVRA comes down to say 6, and you think this is borderline operability, oxygen responsive, this ratio is that ratio is that. Remember, age is a very important here. Any baseline desaturation and an advanced stage generally precludes surgery. So don't think of operating when in doubt. Always don't operate when in doubt. So When it comes to clinical recognition of Eisenmenger syndrome, so I've been teaching like you think of 3 subcategories of Eisenmenger syndrome. The commonest category that we all have, Eisenmenger syndrome means we think like that, is there is a history of failure to thrive. The failure to thrive starts at around 6 weeks of life, because by the time the PVRA will be very high and the PVRA reduces, then the left to right shunt increases and then signs of heart failure sets in. There is failure to thrive. There is recurrent success cycle, recurrent respiratory infection, further weight reduces, further heart failure. This cycle keeps on going. But once obstructive pulmonary artery changes happen, the PA pressures become systemic and the shunt reduces. The QPQS reduces, goes on reducing. The patient has a settle phase where the patient is minimally blue or gets blue on exertion, but patient resting wise is fine, very minimal limitation of activity. And then they present with symptomatic adolescence. The middle one that I've written is the one that we commonly have a concept that this is how it is. But various series from India have clearly documented around 30 to 40% of patients have an insidious onset presentation. They are never diagnosed to have a VSD in life, or they are never told to have a recurrent respiratory tract infection. They just present to you in adolescence with symptomatology suggestive of Eisenmenger syndrome. Very, very few present in adulthood with the first group, that is cyanosis since birth, which is like the cyanosis with increased QP physiology who become Eisenmenger syndrome, like the transposition of great arteries, you have truncus arteriosus with Eisenmenger syndrome, all those things who are cyanosis since birth can be there and they become Eisenmenger syndrome. So there is no in-between area where they settle down. And generally, we don't see them often because most of them die before they reach adolescence. So what is the reason for this insidious presentation? Why don't they have symptoms of heart failure? They are having such a large VSD. They are having such a large VSD, and they are just presenting to you as Eisenmenger syndrome at 20. And they're never diagnosed to have a heart failure. They're never diagnosed in their childhood to have a murmur. Why this happens? When the examiner asks you this question, the immediate answer has to be non-regression of fetal pulmonary artery circulation. So generally the PVRA goes down after the birth, but in some patients it just doesn't fall. This percentage is more if you have a large VSD. So persistent fetal pattern goes on, the pulmonary vascular resistance. So they never go through the circle of increased QP. This is an important concept to understand. So patients who are going to have ASD it's very rare. ASD developing Eisenmenger syndrome is very rare, but if they are Eisenmengerization has to happen, they are likely to be cyanotic at earlier age. So for example, reverse of this, like for example, if you look at a mixing, because if we are going to look at how much right to left shunt happening at each level. So if you look at, for example, TGA, if you have a child with TGA, you always tell like which is the best mixing chamber. It's always the ASD which is the best mixing happening. So if you have both the pressures are equal, ASD, more mixing happens, more right to left shunt happens at the ASD, because the whole cardiac cycle, right to left to right can happen. So if you find a Eisenmenger syndrome in early age group, ASD are more cyanotic. Then generally JVP, a prominent A wave is seen in around 20 to 90% of patients, and B wave is uncommon, is seen in only 5 to 20% of patients, particularly if they have, say, LV to RA shunt or a TR or an MR. So depending on the various etiology of Eisenmenger syndrome, there could be cardiomegaly. So for example, ASD Eisenmenger syndrome, you will have cardiomegaly and you will have parasternal lift. Whereas in VSD, because a large VSD is decompressing, heart failure is uncommon, cardiomegaly is uncommon till end stage, and left parasternal heave is not there. Like you don't find a left parasternal heave in tetralogy. P2 is generally loud and palpable in 2/3 of patients. An ejection click is generally heard in most of the patients. EDM of PR, this is another thing that is very commonly found, but oftentimes residents don't pick it up, is in half to 2/3 of patients, and 10% it may have a thrill. So whenever you find a patient whom you find a good EDM and you are not able to feel the peripheral signs of AR, or a patient is blue, always think of PR as another possibility to AR. So S2 is single in 50% of ASDs and 5 to 20% of PDA and 20% of ASD. So this is something that you have to remember that you can quote if you are caught. But wide splitting is rare in BSD, but obviously it's common in ASD and it may happen in PD also. So how is it different? Like basically, this is generally cyanosis is mild. There is cardiomegaly is not there, and heart failure is not there, and minimal or no left parasternal lift will be there, and absence of significant shunt murmurs will be there, and usually the signs of PH predominate. A constant ejection click of pulmonary artery hypertension and pulmonary regurgitation murmur can be there. So in general, you may be asked, what are the signs of PH, clinical signs of PH? So palpable P2, you can have a palpable RVS3 or RVS4. Palpable pulmonary artery pulsations are very common finding that is often not reported by the fellows. Very rarely, you should look for peripheral bruise in a patient who is suspected to have PH. This could be because of a continuous murmur in axilla, because of CTPH. There could be evidence of pleural effusion. When it comes to auscultation, auscultative signs of pulmonary artery hypertension, you will have loud P2. So even though this is not the primary topic of discussion here, but I think commonly when you say loud P2, immediately you will be asked, how do you say it's loud? This is an invariable question. Like this is like, you know this question is going to be asked. Still, you don't answer it properly. That is because we don't practice. We don't think about it. So why the P2 is loud? It is compared to A2, it is loud. If it is palpable, it is definitely loud. If P2 you are able to distinctly hear at apex, it is loud. Keep it simple. You have RVS3 or RVS4. You have a constant ejection click. You can have a murmur of TR, and you can have an ejection systolic murmur and a murmur of PR. So all these are features of pulmonary artery hypertension. So some of the related questions that can be asked is like, for example, if you find a patient with VSD with AR or VSD with PR or VSD with, say, Eisenmenger syndrome. So how do you differentiate between low pressure PR or a high pressure PR? So murmur of high pressure PR is going to be, sorry, TR. So high pressure TR or a low pressure TR, how to differentiate? It is pansystolic murmur or an early systolic murmur with variable duration. The pitch of a high pressure TR is going to be high, whereas a low pressure TR is going to be low. The shape is a pansystolic murmur, classic pansystolic murmur, whereas it's an early systolic murmur, which is a decrescendo murmur. So P2 is generally loud, and you can have JVP, you can have CV waves. Whereas P2 is normal in low pressure TR and JVP is variable. Same way, how do you differentiate between low pressure PR and high pressure PR? Because some of these conditions, all this discussion may happen. So again, the same high pitch will be there in high pressure PR, whereas it will be low pitch. The duration is generally longer, whereas a low pressure PR is a brief and a decrescendo murmur. There will be other features of high pressure, the pulmonary artery hypertension will be there, like palpable P2, and the P2 will be loud and narrow or soft and variable. If you find a prominent PR murmur, always think of PDA with PH. Mind you, one important caveat here, if you have a PDA with PH and you have a loud murmur, still you can have, at times you can have a bounding pulses like. So that is one reason where you can actually get it confused with AR. So in a patient who is presenting with severe pulmonary artery hypertension with VSD, the important differentiation has to be from Eisenmenger syndrome has to be differentiated from patient who is still operable. That means who is still having hyperkinetic pH. How do you differentiate that? So as I told you, the X-ray, that's a very classic X-ray. If you're not into this field, for example, many of your adult cardiologists may not be knowing all this. So that X-ray is very classic. A patient who is hyperkinetic pH has a huge heart, large flow, whereas a Eisenmenger syndrome, no cardiomegaly, chinky heart, nothing. It's like large central pH and peripheral pruning. So same thing will be there. And a characteristic hyperkinetic pH patient is generally younger. So it will be a child, few years old. Whereas obstructive Eisenmenger syndrome are generally adolescent age group. The heart size is large and heart size is normal. The parasternal impulse can be hyperkinetic, and here it's always silent. And click is generally absent in hyperkinetic pH, whereas it is present in Eisenmenger syndrome. So depending on the various features like ASD, VSD, or PDA, it will be variable. So it is going to be wide and fixed in ASD, and it is going to be wide and fixed in ASD in either Eisenmenger syndrome or hyperkinetic. So oftentimes the width of the splitting may come down, but it's very unlikely that you would have auscultated or documented it earlier, and now you can auscultate it again after a few years and say this is really wider, it's narrower than before. So it will be generally in an Eisenmenger syndrome with ASD, still it will be wide and fixed. Whereas in VSD, if it's a hyperkinetic large flow situation, you will have an S3 and a wide and variable split of a VSD, of a split. Whereas if a large VSD with obstructive PH, generally it will be single. PDA can have a paradoxical split, and in obstructive PH, generally it becomes normally split. And you will have a shunt murmur that is there and a flow murmur that is there. You will have an LVS3 or a MDM at the apex, and you will have a flow across VSD because large flow is flowing across the VSD and pulmonary artery. You can have a flow murmurs, shunt murmur as a flow murmurs can be there. Generally, in Eisenmenger syndrome, very rarely you find a loud murmur and a deeply blue patient. So this again, I'm showing the classic X-ray, so that you understand the concept. Like a hyperkinetic pH, still the patient can be operable. Patient is not blue, and there is cardiomegaly. There is hyperkinetic apex. There is apex is cardiomegaly means dilated apex. LVS3, apical rumble, and a flow murmur. The VSD will be producing a murmur, and there will be flow murmur across the pulmonary artery, even though click is uncommon. So now coming to the differentiation between which Eisenmenger you are likely to have. So I'm again starting with the X-ray so that you understand the concept nicely. So ASD, what is classical about ASD compared to VSD and PDA? There is cardiomegaly. So ASD Eisenmenger syndrome can have cardiomegaly. And they have huge dilatations of PA because they are generally older and they have been having this large flow. So most of these ASD Eisenmenger syndromes have had a long-standing volume overload as well as pressure overload of the right side. So they have cardiomegaly, they have large dilatations of PA. Whereas VSD, you don't find a dilated heart. You don't find generally any chamber enlargement. In a PDA, you can rarely have a PDA segment calcification, or you can have the PDA segment full here. The PDA segment may be full here between the aortic knuckle and the PA. The PA is dilated. You can have a PA segment that is full. Very rarely you can have, generally in a hyperkinetic PDA, you will have an ascending aorta dilatation in addition to VSD. That is how you differentiate. I think you had a lot of classes on X-ray, so I won't be going into the detail of this. And the most important differentiation is presence of differential cyanosis. So what is the commonest underlying lesion? If you have to give in an adult series that are commonly found in today's time, a vast majority of them are, more than half of them will be VSD, and around 1/4, roughly around 1/4 to 1/3 will be ASDs, and around 1/4 will be roughly around PDA, and rest of them will all contribute to around less than that. So these are the current contemporary Indian series. Like they are there. Like I think major centers have published their data. So these are the average mean age of our patients. Like around they are in the 20s and 30s. The ASD and VSDs remain the commonest thing, except for one other series where I think it was equal. But mostly they are done. And most of the patients you can see, they have a very well preserved, reasonably nicely preserved. Most of them are in NHA functional class 2, and they are having a reasonably good 6-minute walk distance. So before we go to the differentiation between ASD, VSD, and PD Eisenmenger syndrome, so let us answer this question so that you retain a lot of information. Which one of the following clinical sign is unlikely in a VSD with Eisenmenger syndrome? Uncomplicated one. Single S2, palpable second sound, cardiomegaly, absent parasternal heave. You thought over your answer? So if your answer is cardiomegaly, you are right. So this is, I think, a very important table that all of you should remember. So the usual age of Eisenmenger syndrome can be around 2 years of age, and PDA, it happens earlier. ASD is roughly around 20 to 50%. And differential cyanosis is found in 50% of patients in PDA. Rest of them, some of them actually, around 25 to 30% actually have cyanosis everywhere, cyanosis in upper limb also. What is the reason for that cyanosis? If anybody wants to answer, they can put it in the chat box. You understand the question? So differential cyanosis, why some patients with PDA Eisenmenger syndrome are having cyanosis in the upper limb also? What are the possibilities? You can put it in the chat box. Other important thing is cardiomegaly. Cardiomegaly is not found in VSD and PDA, whereas it is almost universally found in ASD. S2 is single, whereas in PDA it is narrow or normal, and in ASD it is wide and fixed. And parasternal heave is only found in ASD. It's not found in VSD and PDA, a significant parasternal lift. And TR murmur most likely means ASD, and a PDA murmur most likely means PDA. So the points in favor of PDA include a differential cyanosis, a normal or a narrow split S2, and a PR murmur. And lot of things favor ASD, presence of positive things favor ASD. That is cardiomegaly, wide and fixed S2, a parasternal heave, a murmur of TR. If nothing is there, which is most often the case, just a single S2 with a soft murmur, with a mild cyanotic patient, it has to be VSD with Eisenmenger syndrome. So in clinical medicine, it's all about recognizing the pattern. The more money is on recognizing the pattern than particularly fixing on one particular finding or one particular sharp thing, because very rarely you'll be right. So you identify the pattern, most likely you'll be right. So this is the pattern that I want you to remember. So if you don't find anything, nothing is there, just as like I told you in tetralogy last time. So you don't find anything, literally no examination finding except a single S2 and a soft murmur, and a murmur is there. And same thing here, no parasternal heave, no cardiomegaly, no nothing. Generally it is VSD. If you find everything, generally think of ASD. If you find cardiomegaly, if you have a wide fixed X2 and you have a parasternal heave, you have TR murmur, all of them support S2. So we'll briefly go through Epstein's anomaly and some discussion about other conditions. So some of the characteristic conditions, like I think last time Dr. Sumodh was telling that we should follow the various classifications that have been proposed for cyanotic congenital heart disease, that I agree. So if you are a pediatric cardiologist practicing in pediatric cardiology, I think you should definitely follow that classification only. If you're an adult cardiologist, this group of patients you rarely encounter in adult practice. So this is cyanosis with increased pulmonary blood flow. A prototype being a TGA with VSD. So you have a symptomatic period in neonatal period, and cyanosis is generally severe. Now, initially, the transposition physiology or admixture physiology is producing cyanosis. Over time, they have early onset of pulmonary arterial hypertension. Now, pulmonary arterial hypertension, right to left shunting is also contributing to cyanosis. Generally, they have both the things like failure to thrive, congestive heart failure, cardiomegaly, and there can be S2 single, S3 will be there, and there will be a insignificant systolic murmur. And on X-ray, you will find cardiomegaly with increased pulmonary blood flow on X-ray. This is a typical prototypic patient, but oftentimes we don't find it in you kept in your exam because they are not found at that age. So what are the other differential diagnoses for such a thing? That cyanosis with increased pulmonary blood flow is transposition physiology, TAPVC, truncus arteriosus, single ventricle without PS, double outlet right ventricle with a large VSD, no PS, tricuspid atresia with large VSD with no PS, and AV septal defect with large VSD. Generally, it behaves like a Eisenmenger syndrome unless there is a large component of common atrium or other things. So another group of condition that you have to know is cyanosis with pulmonary venous congestion. That is obstruction in obstructed TAPVC or HLHS group of conditions. So you have generally presentation in neonatal age group, and generally they are lethal unless intervened early, and there is marked respiratory distress and cyanosis, and there is no cardiomegaly. Why there is no cardiomegaly? Because they are obstruction, and there is a large pulmonary arterial hypertension develops early, and most of them have an ASD which is shunting right to left, and there is no cardiomegaly. And then generally they are generally neonatal emergencies, and they are difficult to differentiate from respiratory distress syndrome. They produce something like ground glass appearance of the thing. So rarely you find another group of conditions. Very rarely you can find cyanosis with normal pulmonary artery pressures without pulmonary stenosis. So unobstructed TAPVC, you have clinical features of ASD. That means wide split S2. You have a RVS3, and you have a flow rumble at the tricuspid valve. That is cardiomegaly. Yet the patient is mildly blue. Everything looks like ASD, but the patient is mildly blue. Indicates it could be TAPVC or it could be common atrium type presentation. Epstein anomaly is something that you have to, I will come to that later. You generally find quiet precardium. That means not much parasternal heave, no cardiomegaly, no parasternal heave, no palpable sounds, but you have multiple heart sounds heard. That means Epstein's anomaly. Generally, very rarely you will find some cyanosis with normal cardiac examination, but you should know about them. They may be useful in your viva. That include unroofed coronary sinus, total anomalous pulmonary venous drainage, total anomalous systemic venous drainage, or you can have pulmonary AV fistula. How do you make a diagnosis of pulmonary AV fistula and echocardiography lab? We use agitated saline injection. Immediately, if it fills, the left side, generally it will be because of an ASD or a VSD or a PDA. If it fills after 3 cycles, generally that is diagnostic of pulmonary AV fistula. So coming to Epstein anomaly, always remember in your exam, always think whether the Epstein anomaly will be a possibility in this particular patient, especially at the end of history. Most of the patients with adult cyanotic congenital heart disease, unless they have a classic history of squatting or classic spells, they may give you some features which are actually fitting into Epstein anomaly. That should be your third differential diagnosis if it is fitting. So what are the clinical findings you find? You find a cardiomegaly. You find JVP. What do you find in JVP? JVP, despite the RA enlargement, because its RA becomes so roomy, RA dilates, but still the pressures are not high. JVP in general remains normal. What type of murmur is produced? It's a low pressure TR murmur. So what are the multiple sounds you can have? Multiple rhythms can be there. You can find T1, M1, wide splitting. You can have tricuspid opening snap, which generally occurs prior to mitral opening snap. You can have RVS3, you can have RVS4. So all these findings can happen. And you must know what is an early systolic murmur. So often this is a very basic question that many of the examiners are fond of asking. What is the difference between an early systolic murmur and an ejection systolic murmur? So you have basically a pansystolic murmur that goes from throughout the systole, a pansystolic murmur. When the early systolic murmur happens, immediately after S1, and it's generally a decrescendo murmur. When the ejection systolic murmur happens when the aortic valve opens. That means there's a small gap, and that gap is the isovolumetric contraction. So if you find an ejection click, you remember like this, if you find an ejection click, that is where the valve opens and then the ejection systolic murmur starts. If you find an early systolic murmur, what are the differential diagnoses for an early systolic murmur? Either it has to be an acute MR or a low pressure TR, or it has to be some form of VSD, that muscular VSD that closes off. Because it has to start when the ventricle is contracting and the aortic valve is not yet open. Am I clear here? So you find an early systolic murmur, and it has a typical ECG, and you have many X-rays that are there. So they can present to you with WPW syndrome, flutter, VT, and they can present to you with, rarely they can present to you with actual heart failure and TR. And very rarely they can have such loud murmurs. It can actually confuse you in the exams also. So always remember that Epstein should be always kept in your differential diagnosis for an adult patient who's coming with cyanosis. So I think I will briefly touch upon the common issues that you must be aware in a patient coming with adult with cyanotic congenital heart disease before I end. So what are the common problem that happens in cyanotic congenital heart disease? So remember that cyanotic congenital heart disease in adulthood is a systemic disease. It almost involves all the organs of the body. So there could be heart involvement in the form of myocardial dysfunction because of hypoxia. So we have seen patients who present, like as I told you in the last time, like in some other tetralogy patients, they can have cyanosis-related LV systolic dysfunction, and we do a shunt, and the LV function improves, and then later on they have undergone corrective surgeries. So AV valve regurgitation is another problem that happens commonly. And then this is another commonly recognized feature that cardiac involvement that happens over time is dilatation of aorta and secondary aortic regurgitation. And a lot of aortopulmonary collaterals happen, and because of that, they can develop hemoptysis. And obviously, most important cardiac event that decide their fate will be generally early and late arrhythmias. And obviously, all of them are predisposed to infect endocarditis. So these are the major cardiac effects of cyanosis in an adult patient. Coming to non-cardiac issues, almost every system is affected. The most common, most important ones are hematological problems like polycythemia, and relative anemia is very common. If you are interested, you should know what should be the ideal hemoglobin for a given saturation. What should be the ideal hemoglobin for a given saturation? That's a given, and there are formulas available. You may know that. Neurological, I think brain abscess is a very important thing. Always you must consider. And stroke and cortical vein thrombosis, cerebral venous thrombosis can also happen. Hemoptysis because of either aortopulmonary collaterals or various other hematological issues, hemorrhagical issues are also found. Ultimately, various combination of lesions lead to a lot of forms of renal diseases in the form of either glomerulopathies, or it can be urate nephropathy. A lot of other things also can happen. Arthropathy, patients of cyanotic congenital heart disease can have arthritis or have joint pain because of various reasons, including not limited to hypertrophic obstructive osteoarthropathy, or it can be gout, or it can be pseudo gout. That means calcium pyrophosphate deposition. All the three are generally found. So some of the other important issue will be pregnancy and contraception, what to do with non-cardiac surgery, and dealing with employability, insurability, and the psychosocial issues. These are in the red because I think nobody cares about them in India, because we don't have dedicated specialty for adult congenital heart disease in the country as yet. But most important thing, why repeatedly I wanted to deal with, even though these are all not something very important to adult cardiologists, but I still want to include is the least that you can do is please do them no harm. So as I told you, 20% of deaths in adult cyanotic congenital heart disease happen because of unwanted procedures and pregnancies being allowed. So another important thing that you should know is pregnancy and congenital heart disease. What are the ones that are absolute contraindications? One is pulmonary hypertension. Those who have severe pulmonary hypertension, those who have Isomeric syndrome, they're all contraindicated. Severe LV systolic dysfunction generally is a contraindication, and Marfan syndrome with dilated aortic root is a contraindication. And uncorrected cyanotic heart disease, possibly better to correct the cyanosis. But if you have become pregnant, I think you can take a chance if the saturations are reasonably good. Mostly you'll be asked about, suppose most of the time you will find a patient who has become pregnant in between the history. So you'll be asked about pregnancy outcomes. This is one slide that that tells you a lot. I think you understand that the maternal mortality, maternal outcomes are the worst in Isomeric syndrome group of patients. Whereas coming to the fetal outcomes are really very bad in Fontan, pulmonary atresia, group and severely cyanotic patients, where the completed pregnancies are the least. So this, I think if you remember this, and some of them are very well tolerated, like for example, PS is absolutely well tolerated, both by mother as well as the fetus, and many of them are in between. So risk to the fetus is, if the saturation is below 85, in the early pregnancy, the chance of live fetus is only 12%. So this is another important slide that I think often you are asked, like what is the risk of the CHD in the fetus? If the father is affected, the mother is affected, if the previous sibling is affected. So Marfan syndrome, we all know that it's 50%. And if the father is affected, the most important thing is aortic stenosis has the highest risk. And ventricular septal defects and atrial septal defects, if the mother is affected, has highest risk of thing, and most of the conotruncal septal defects generally have higher penetration. Previous sibling is roughly around 2% risk to the fetus. So fetal echocardiography should be offered at around 16 to 18 weeks in most of these patients who have a sibling affected. I think I thought of covering some of the X-rays and ECG, but I thought maybe ECG in congenital heart disease can be separately dealt because there are so many things to deal with it. So I thought, I think managing an adult with cyanotic congenital heart disease needs a lot of vision and expertise. And some of the resources you should read will be, I think, some of the textbooks that are there. And our cardiology clinical methods, a lot of this information is given. And this book by Dr. K.C. Goswami is extremely good and gives you a lot of valuable information, essentials of PG cardiology. So I think that is a good read. I think you must read that. So I'm open to questions.
Thank you, Dr. Rama. Thank you so much for making the things even more simple. So we have practically also covered very nicely the nuances and the intricacies of the Eisenmenger syndrome, the approach, and what are the other aspects of cyanotic congenital heart disease that one should be aware of. Very interestingly, as you very nicely highlighted, that 20% of the major reasons are because of the improper decisions that are taken up by the physicians and recommendations which are not recommended. So even if you let the patient live of Eisenmenger syndrome, the prognosis is much better as compared to the idiopathic pulmonary hypertension. So that curve particularly and that particular study is very, very important, and all the fellows and residents must be aware of that. So any other thing that you would, as a article that you would specifically recommend for our residents that they should be aware of? Because you're right that we have moved ahead of the Paul Wood series now. So there are many other contemporary, like your own series, one of the very important series that we have. Any other particular article that you would strongly recommend that doctors and residents should be aware of the latest series that is quotable in the exam?
I think I would recommend, I think for all adult congenital heart disease, even though that is, the examiners have not read that, but I think still I would feel one of the important things to understand and read will be the adult congenital guidelines from ACC.
Yeah.
So that's a very useful document, but unfortunately, many of the examiners are not aware about it, and many of them don't ask about it. But still, I think if you know, a lot of concepts will be very clear, and a lot of them are evidence-based and quite nicely presented.
Dr. Sumod, Dr. Grish, yeah.
Yeah, when Dr. Rama is there, we can ask all the tough questions which need answering. We see a lot of VSTs, a lot of PDS, but not all of them may develop, irreversible change. We may still find many VSTs who are older, still left right shunt. PVRI may not be very, very. Why only some? I'm sure, sir, you would have thought about that. Why only some of them develop and others does not develop irreversible changes?
I think it's a very tough question, and we are the ones who should have answered this question with some studies, but unfortunately we haven't done anything, documented anything. So one of the things could be, like, for example, some of them who develop early Eisenmenger syndrome, they could be having some of the congenital mutation that predisposes them to PH. We try to do that, but we are not able to prove that. So that's possibly there could be some genetic linkage to this, but more and more I think that it is the pulmonary vasculature's capacity. And for example, if you put a patient, for example, all of us are normal, so-called normal. So we are given hypoxia. The amount of vasoconstriction that develop in your pulmonary vasculature varies by 40-fold between individuals. So there, I think there's a big difference. Some of them, they don't vasoconstrict so much for a given level of overshunting. So possibly it is about pulmonary vasculature and the pulmonary parenchyma's ability to take that flow. If the pulmonary capillaries are able to take that flow, accommodate that flow, possibly pH doesn't develop, that amount of obstructive changes doesn't develop. That's what I think.
Yeah. Something unexplained factor.
We don't know. We don't know. Primary answer is we don't know. We agree with you. Like I've seen a 20-year-old who is still having 2.5:1 or 3:1 shunt with a large heart, with a huge VSD. But we don't know why he's still operable. I don't know. But by and large, that number is pretty large because we are in a very big referral center. We keep on seeing them. But for that one patient, we would have seen hundreds and hundreds of large VSDs who have become isomenger.
Sir, what is your baseline PVRA beyond which, sir, you will not do an oxygen study, or you will do oxygen study for everyone, or patient is not clinically cyanosed, patient is not this thing, but baseline PVRA, what is your cutoff? One is, what is the cutoff of inoperability? I'm not going to do oxygen study. This is sure. Inoperable. And we generally take different PVRA values for that, AST, VST, PDA. Why do we take these different PVRAs for different lesions?
I think these things, some of this I have answered in my operability paper. I think I presented one operability testing paper, so that I've discussed. Unfortunately, this again is another area where there are no data. So this is not data driven. These are all consensus given guideline. And if you look at the data, they were all based in the 70s studies. Like the cutoff, where this cutoff came from. These cutoffs are like not current evidence. They can't stand the current evidence. So the data that we have, they don't stand the current evidence, number one. There is no randomized control trial of operating somebody beyond a particular PVRA, and what happens, we don't know. And most importantly, even you're saying that we are trying to relax some of the criteria. We have been operating beyond 8, for example, 8 PVRA is considered, but 6 PVRAs used to be the textbookish thing, but many people consider 8 as the Lakshman Rekha beyond which you should not operate. But we have been extending it in some indication, like for example, people have operated in some patch closures. We have also done at 12 PVRA, and some ASDs we have operated later. But the issue remained that even then, many of them still have a high PVRA and follow-up. Whether we have really helped them or not, we really don't know the long-term data. So some of the minimum long-term data that is available with us also, for example, there are good series from Sri Chitra by B.R.J. Kannan and one series from Dr. Subramanian. They suggest that even then we have carefully chosen the patient and operated on them. We have possibly not changed their natural history for their benefit. Still, they all live with a high pH and high PVRA. And then another important confusion that has happened is this treat and repair approach, and repair and treat approach, and all those things. There is very little evidence again. And if you look at the literature that has been published, I think Dr. Aravind and Dr. Kothari has published all the available evidence put together, and it is minuscule compared to the cardiology evidence that we have in front of us, like compared to other fields. So the treat and repair approach, we are very happy to operate. But the problem is, for example, what I'm trying to say is, we are absolutely not sure at all what are we deciding and what, because we take the decision and the patient takes the risk. The problem here is that you operate an 80-year-old, you think that it's borderline, oxygen steady state is come down, but you are going to burn your finger at 20 years of age only. If he has to Isomeric and come back with right heart failure, he's going to come to you at 18 or 20 years of age only. So that is where the problem is, that even all of them may not die immediately post-op, all of them may not improve. But on the other way around, like we also published some of these series with Sachin Talwar. We have operated a few VSDs, which are carefully chosen. Obviously, it's chosen by some other experts in this field who have really thought about it a lot. Each individual patient is given a lot of time and thought. We have operated upon beyond these limits of PVRI. Still, on cardiac catheterization and follow-up, many of them have reduced the PA pressures have come down. So on either way, we can be wrong. So this is the problem. Here, I would after seeing so many patients, I am not sure that we can definitely say one number beyond which you should not operate. But for exams, they have to know the criteria. They have to repeat those criteria and pass the exam. But unfortunately, in practice, I don't think that I will say one particular number, and that number will be definitely determinant on age. But none of the criteria give you that kind of a sense. So, for example, I am happy to operate a 9 PVRI at a 1-year-old child, whereas I'm very hesitant to operate a 9 PVRI at a 20-year age. They are totally two different beasts.
Yeah, the second question was 6, 8, 10. Generally, many people use for AST, BST, PDA, 6, 8, 10 PVRI cutoffs. Why we?
I'm not sure that they are all data driven.
Sir, do you have such a differential treatment for different lesions in
No.
AIMS?
No. Like we don't have one particular number beyond which we don't operate. There is nothing like that number. That number is definitely most important determinant for me in operability decision making is not PVRI, but age of the patient.
Oxygen therapy is again, there are many people who advocate that only go by baseline data. That will be oxygen is a very erratic kind of a assessment. So, what do you, sir, you have to say? Go by baseline data, or should we still do oxygen studies at this time? Because most centers NO is not available, so one has to rely on oxygen.
Still, I think oxygen data is quite useful in some of the borderline situations. It can actually reclassify. It can reassure you that your decision making is right in your baseline set of data. But never rely upon only oxygen data. Everything looks inoperable. Just your oxygen data is operable. I am guarantee you that you will burn your fingers maybe 5 years, 10 years down the line on follow-up.
This S2 persistence split, I think we keep asking everyone, but I think to get your opinion, sir. S2 persistence split in AST, despite there is no shunt across AST. We can understand why it is due to the wide hangout, but there is no respiratory variation that is now occurring once there is no shunt. So how do we explain the split remains persistent even after a device or even after Isomenger? Why does there is no real decrease that can be attributed to the shunt level?
I think with the device, I think it's not. It can remain wide and fixed, but it's not the rule. Like many of them, if you do it early, it can normalize also. So I think it is roughly around 40%. If I remember correctly, roughly around 40%. It still remains wide and fixed. So why it remained fixed will be again like if you're asking about Eisenmenger syndrome, it is pretty easy. Like not much respiratory variation can happen because of a large VSD is there. After closure, why it remains fixed? I really never thought about it. Maybe I can think over it and tell you the answer. I don't know really. You must be knowing the answer, like why?
No, sir. In a normal patient, we say that there is a increased venous return, which will be compensated by a decrease in the shunt. Probably that's the reason. But in Isomenger, there is no shunt. Isomenger, there is no shunt to decrease.
Why it remains fixed? I don't know. I really don't know. Maybe after closure, if the shunt is also not there, why it remains wide and fixed? Wide you can understand, but why it remains fixed, I really don't know.
Other issue about pH is VST with Isomenger, but if there is something that can produce elevated venous pressure like hematostenosis and all, even at 80% saturation, 85% saturation, they can still remain operable. That is again a thing that is commonly said. If you have something that can raise the pulmonary venous pressures and there is a pH, how does pulmonary venous pressure? I think the same correlate apply even for hematostenosis. We see such severe pulmonary venous pH, but most of it may regress after treatment. It will not go into advanced heat, advanced stage and all. So how does PVH can protect against this irreversible pH? What is the reason, sir?
So I think the basic reason is like for example, if anything to this to happen, what Dr. Sumodh is saying, if this has to happen, this has to be severe mitral stenosis. If the patient has mild stenosis, still the patient can be inoperable. If the patient has severe mitral stenosis, severe obstructive lesions, then only this principle applies, and these are all Actually, if you look at it, they are all anecdotal case reports, and there are hardly not more than 20 patients, such patients would be reported. But we have seen clearly patients operated, nothing, their PVRI comes down, their pressures come down. So why? Because like it's about a process. Like if you understand Eisenmenger syndrome as a process, they are unlikely to cross that process. Like because already there is a, like for example, if the PVH is around 20-25, there is going to be that amount of contribution to the pH, to the mean PA pressure. If you're able to relieve the obstruction, some of them is definitely going to be reactive. So how much is reactive? How much is obstructive? It can be variable. Like for example, in a given patient with mitral stenosis also, that variation happens. So somebody can have 100 PA pressures and somebody can have 40 PA pressures with severe mitral stenosis. So that amount of variation happens. But many of these BSD, since they have a systemic pressures going in their pulmonary artery, they generally have systemic PA pressures, and their mean pressures also gets elevated. You are taking care of two things. One, you are reducing the PVH and you are reducing the systolic pressure. Most often than not, the PA pressures comes down, but generally in our experience also, it never normalizes. So there is still some amount of residual pulmonary hypertension that remains in these patients, but they are generally not Eisenmengerized.
So pregnancy is an absolute contraindication, we say, but in our setup, invariably many people come in the second trimester with pregnancy in Eisenmenger. And one major issue we face is that the gynae people are against doing a second trimester abortion. They say doing a second trimester abortion is as risky as doing a full term this thing. What is your in AIMS? What is the experience? Do they do a second trimester abortion, or is it risky to do a second trimester abortion, or is it better to continue pregnancy and do a assisted second stage?
Generally, we have been advising for termination only, even second trimester also. And our people are able to do that. Mostly they do it because I think in Eisenmenger syndrome, still, despite all the advances that we have, I think still the mortality is pretty high. So like 1 in 3 chance of a patient dying, and maybe around 1 in 3 chance of a baby not being alive. So that's too much of a chance you are taking. So if the patient is very minimally cyanosed, when the things are borderline, then we may hesitantly say, if the gynecologists are not agreeing, then we may continue pregnancy. But that is actually not a good, in our experience, that's never a good, there is no way you can judge which Eisenmenger is going to do well in pregnancy or not. Everybody is at increased risk, and preferably they should be terminated. If by patient choice, or if the gynecologists are not willing, then we have no other option.
Other question that is commonly asked is the post-acute shunt, VSD, PDA, AP window, which Eisenmengerizes faster? That is a quite commonly asked question. Although we have less cases of AP window and all available, but and we think that is closer to the pulmonary circulation direction. So what is your opinion about that?
The answer should be AP window, then you have PDA, and then followed by VSD. So because I think it's about resistance transfer, I think if you have a window, it's a window. So it's like a one tube. So it will be same. Resistance will be the same. So it's about what we are discussing here is about diastolic resistance here. So if you have one large tube, the diastolic resistance is also going to be really equal. If you have a narrow long tube or a wide long tube, even though the systolic pressures will be equal, the diastolic resistance can be still different. Whereas in a VSD, it has to pass through a whole thing. So the resistance, there's a reason to suspect that resistance will be different. But if you ask this question, this is the reason why things will be different. As you said, it is nearer to pulmonary circulation.
So some simple formula, I think, again, this is a very common question they ask, what is the expected saturation, what is the expected hemoglobin for this patient? Any simple formula which, most of the formulas are not very simple.
Formulas are not simple. I don't also remember the formula, but I can tell you the reference. I think there is a table that is given in Heart. Sometime later, the hematology book give you a complex formula. So that you can know. I'll get the formula that's there in some presentation. I'll send it across to you. but sent across to everybody. But there is a simple table that is given in heart that was about Eisenmenger syndrome patients. So what is the optimal hemoglobin in a particular saturation in Eisenmenger syndrome? That table is quite easy to remember in overall broad sense.
Sir, actually, nobody replied to your question, sir. Right-left shunting PDA, only 40%, 50% is differential cyanosis. Why, rest of them have uniform cyanosis?
So this is very interesting. I think not much the literature is there. We discussed about it, and we don't know. So one of the very simple explanations will be like there could be a PFO. There could be a mild small muscular VSDs and all those things. That could be one simple explanation. Second explanation could be there could be a reversal, or another simple explanation will be there is an anomalous origin of some of the vessels below the PDA, like subclavian is aberrant and all those things. Those are easy. But the difficult one is that there seems to be some of them, there seems to be some reversal that is happening in the ascending aorta in a PDA situation, especially right to left. That may be another reason, but that is not well documented. That we have been trying to look at that. Like few patients we have looked at, and that's one of the reason. Like there is seems to be some reversal happening in the beyond the PDA into the ascending aorta.
Sir, I think coming back to the question that was asked last time, if you are asking in the exam the pink of why is pink, what will be the best answer, sir, you will be expecting to get?
So pink TERF is pink because of good pulmonary blood flow. Why the pulmonary blood flow is good? Because their pulmonary resistance are lower and they are getting a good flow. So
streaming, we cannot say as a result. Some people say streaming and well, due to some unexplained streaming, streaming of the blood, favorable streaming.
I'm not sure that favorable streaming will be there in tetralogy, but unfavorable streaming is much more likely to happen. Like, so most of the pink tetralogies are generally having a very good pulmonary blood flow. You catheterize many of them, they will be having even a left to right shunt across the VSD, and then even though there is PS, so they will be saturated, they will be shunting around 1.5:1 or 1.3:1 left to right across the VSD.
Someone has this formula, sir. Hemoglobin is equal to 36 minus % saturation upon 4. Can we apply this formula? That's the question. But is this a formula, right?
I think this formula is not specifically for the Eisenmenger syndrome, actually.
But in general for cyanotic heart disease.
Yeah, cyanotic congenital heart disease. So not sure, but as Ramaswamy is saying that, he'll look for that's an article in Heart Sir Journal that you're talking about, Eisenmenger syndrome?
Yeah, Heart, I think, has a optimal hemoglobin discussion.
We are also not aware, but it will be a great idea to look for that nomogram, which is more relevant. So,
I'm not aware of such simple formula. I think otherwise you would have remembered it for this thing. But there's a very complicated formula that is there. We often look at it and then we forget it. Like we don't use it routinely.
Yeah, again, but sir, this formula which someone has shared, 36 minus % saturation. If % saturation is 80, so 36 minus 80 would go into negative.
I'm not aware of such formula. That's all.
36 minus 80 by 4, which is 20. So 16 is the expected hemoglobin. That's what he's saying.
Okay. Yeah. That's how it is. Okay. Oh, so
another question again. When we get Rama, we ask all difficult questions. No, hemodynamic correlation again. My favorite question. Last time we had sir from Jipmer came in, sir was saying PR murmur is there, which means RV systolic pressure is likely to be more than 80. When there's a PR murmur. Any other hemodynamic correlates for any clinical findings that we can apply? That's what
I think unfortunately a lot of things are there, but they are not evidence based. So like for example, if you pulmonary artery hypertension, like so you're talking about pulmonary artery hypertension primarily. So if you have a palpable P2, so generally the mean PA pressures are roughly around 60. And if you go from top to bottom, there is a paper that discusses it, that gives you a different value of systolic pressure for where the P2 is heard. If you're able to hear a P2 here, at least the pressure is 60. It goes down till 90 in the apex. If you're able to hear something at around apex, it's roughly around 90 or 100. So that will be one PA pressure estimation. And obviously, if you are making a very simple and congenital heart disease is based on the shunting across the defect, you can get a lot of hemodynamic information. And in an ASD, looking at the JVP will give you a lot of information. So if you have an ASD, so oftentimes you can actually build up the whole set of data. What will be the likely pressures? Same thing in CCP also. So these are situations we can actually come up with a whole set of data, because you can estimate your pulmonary wedge capillary pressure. From your examination, you can make an estimation of PA pressure. So if you have these, then a lot of hemodynamic information can be obtained. But I think over years we have become less serious about it, and obviously because applicability is limited. So some of the major ones they should know, for example, palpable P2 means severe PAH, and this kind of thing they should know. And if you have a P2 that is auscultable at apex, it's severe.
Okay, so as Rama sir had just said, I just downloaded that article of Heart, and it clearly made, it's not giving a formula, but it does mention that a hemoglobin level of 14 is considered to be low, and ideally it should be maintained at around about 18. So this is what it states, and the reference that it gives us is of European Heart Journal 2011, iron deficiency anemia and Eisenmenger syndrome. So that's a review article of Eisenmenger syndrome published in the Heart. So this is what they have mentioned. So I'll share this article across in the groups, and you can probably go through it. So once it is in review, so you can definitely quote it. So that makes more sense, and simplified.
Is it the one published in 2014? What?
2020. 2020.
Okay.
Quite recent. So I just. So I think Dr. Samoth, if there are any other no more questions, we had a very, very good discussion, and definitely there are certain areas which are unanswered, and I think probably we need more systematic studies for following up these patients. And thank you, Rama sir, for joining us today. It's absolutely fantastic to hear you on this particular topic, but let me tell you that, we will be definitely bothering you for the third part also, maybe sometime later, PGs and everything, maybe sometime later, and this particular platform, which we have never had earlier. Thank you, Sumod, and thank you.
I think what you can have that Rama sir has given a hint also. ECG in
that is what I'm saying. They never seek time because according to his schedule. And thank you so much, Intas, for providing us this platform. I'll be loading this lecture in a couple of days, and you can listen to it. It's a very beautifully and simplified approach to cyanotic congenital heart disease, which takes care and answers most of the queries and questions that are asked in exams. Thank you, sir, for joining us today. Thank you.
Thank you.
Thank you, sir. Thank you, sir.
Thank you so much, sir. Thank you. Thanks.